Our next speaker is going to be Professor Beyer, and the introduction is going to be done by Dr. Moore. Dr. Moore, can you please?
Yes, Dr. Boshamane. Don't know why they put us together, but yeah. So, Professor Thomas Beyer, thank you for gracing us with your expertise. As you may all know, you spoke yesterday, and is a physicist who is training from Leipzig, Germany, with postdoc degrees from Surrey and Essen, and currently doing a lot of work in developing strategies for image patient-guided management, which uses hybrid imaging techniques and artificial intelligence. Thomas Beyer, the floor is yours.
So thank you very much indeed. My task is to tell you about the future of hybrid imaging. You can tell from the changes in the program that the future is unpredictable. and it's a challenging task. I actually need to do a disclaimer. So TB likes TB, so Thomas Beyer likes total body PET, and I'll talk about total body PET in a second. And I was quite fond to see the topic that the SASNM chose for this year meeting, which is going back to our roots. And I chose this as an introduction to this presentation because I was reminiscing my roots. And some of you may know that I actually grew up in former East Germany in the city called Dresden, which was separated from a larger part called Germany before the World War. And interestingly enough, the population in East Germany and West Germany resembles also the distribution of nuclear medicine physician and radiologists in the country. So you could argue that East Germany is kind of the nuclear medicine hub and West Germany is the radiology hub. And those of you who are good at history will remember that in the 1980s there was a revolution taking place where basically East Germany said we want to be reunited, and you could argue that this actually is synonymous with nuclear medicine calling for a unification with a CT, in the sense that the idea for PET-CT was really born in the community of nuclear medicine. And when the country was united, clearly this was resembling a PET-CT, and we had the first chancellor who promised so-called blooming landscapes. And if you were old enough or are old enough and remember the introduction of PET-CT, this was certainly a promise being made by those who loved PET-CT. Now, I should add that at the time that PET-CT was introduced in the late 1990s, the room would have been split in half-half. Those who said PET-CT is the next big thing, and those who said you don't need that thing, you can do everything with software. And in a way, similar perception was with the history here, but I accepted it as blooming landscapes. But 30 years later, it's really, and this is sort of the glooming atmosphere I'm going to shed on the future of hybrid imaging, is still very heterogeneous. And my task is to take away this pessimism and turn it into optimism and tell you a little bit about where hybrid imaging might be going. Now, you might know of the hype cycle, and I put up a few dates here, which I think resemble the hype cycle of PET-CT imaging, at least. When it came out in the 1990s, it was a trigger. In fact, those who voted wrongly at the quiz yesterday, PET-CT was developed, it was conceptualized in Switzerland, but never built there. And it was actually, as we found out later, conceptualized and built in Japan in 1994. In 2000, when the market adopted PET-CT, there was a peak of inflated expectations, but many of those turned out to be well worthy clinically. I think we went through a trough of disillusionment, as you will hear in just a second from my talk, and we're now about here. I think we're far away from the peak use of hybrid imaging yet, but I'll tell you more about it. So the first take-home message, I think hybrid imaging, if you come to think of it philosophically, is a societal issue. We talk about it, we want it, we get it, but we have to accept that we also have responsibilities to make it happen. Before we talk about the future, brief glimpse of the past. Imaging is something extremely exciting. It allows you to non-invasively probe aspects of the human body and, of course, animals, if you do small animal imaging. It started with the invention of X-rays, and as you see, 50 years later already, a plethora of imaging modalities were introduced that again 50 years later found combinations. They basically married. So there was an engagement going on, and we have at least 3 hybrid imaging modalities that now made their way into clinical practice. So imaging has become non-invasive from the times of Da Vinci and multiplexed. And the history of hybrid imaging goes back to the 1960s when the first users essentially drew anatomical contours on scintigraphs to better localize thyroid and thyroid nodules. This was later met with attempts to fuse photography and X-ray or scintigraphy. It moved on into software developments. We've seen an extensive lunch presentation on this today. It's still around and will not be defeated by PET-CT. In 1990, those algorithms got more advanced, and in 2000, you see late Bruce Hasegawa, the inventor of SPECT-CT. PET-CT came about, and PET-MR, as Dale indicated yesterday, around about the same time. And in 2010, the market was really taken aback by the onset of this hybrid imaging modality as proposed by different vendors. What is in common of hybrid imaging modalities? First of all, we do it for co-localization. We need it, it's required if you have specific PET traces or SPECT traces without any anatomical background information. No way around hybrid imaging as a hardware solution. It provides added diagnostic benefit because of the power and the specificity of PET and anatomical correlation. And at least for SPECT-CT and PET-CT, it provides a time benefit where by exchanging traditional transmission sources with the CT, the exams can be shortened. And it's important to recognize that all the advances on the nuclear medicine technology side were promoted only on hybrid imaging platforms and not single PET or SPECT systems anymore. Now, what is the magnitude of hybrid imaging today and where will it be going? We have about 6,000 PET-CT systems, 1% being installed in Africa, which is a shame, the rest worldwide. The adjusted growth rate is 6%, and the total market volume is about $3.2 billion by 2030. PET-MRI, this is actually wrong. It should be, I'm sorry, what? Killed me. Because I made a mistake. Can I get the slides back? Sorry, how do I get back on this thing? Can you help me go back one slide, please? Yeah, thank you very much. So you see I made a mistake. This should be SPECT-CT. I mixed up the images. I'm sorry. So much for being engaged 30 years in hybrid imaging. There are about 10,000 SPECT systems. I would say half are SPECT-CT. The annual growth rate is the same as PET-CT, market volume $3 billion. And you see the images being swapped. PET-MRI, 400 systems operational worldwide, an excessive growth rate of 10%, and the market volume is a fraction of the other markets, but certainly are growing. All 3 are established in the market, commercially available. You know, and I don't need to repeat this, hybrid imaging is now fully quantitative. It's 4-dimensional. It's sensitive and specific. And we have proven clinical impact of all 3 combinations, and there's a growing industry, interest in industry, and a growing industry with these growth rates. Now, moving to the future, I'm here to sort of shed some light onto where we think, or you can debate it, where we're going. Niels Bohr, famous physicist, said predictions very difficult, especially when it's about the future. I can only agree. So looking ahead, I think firmly hybrid imaging is going clinical. It's been there, it will stay there, and we have enough proof to actually convince stakeholders in the healthcare system and people who engage in patient management to say this is worthy investing in. And you can consider hybrid imaging also as gatekeepers to expensive personalized therapies. And we've heard in the previous session some examples about where this is of use. Now, going hybrid also means going to read the scans, and this is a comic that we actually created in 2001, and I think it still holds true in many areas. And me being a physicist, taking an interest in physics of radiology and nuclear medicine, I always struggled why there is so much debate about who should be reading scans when you could actually address this with a proper training. I was co-involved with some educational developments promoted by ESR and ENM back in the 2005 years. You see two key papers there where both societies agreed that it takes the support of both professions to make it a worthy examination. But honestly, it hasn't changed much. Anecdotal changes, but I don't see a global change towards making this an efficient reading experience. As a token of, or a seed point for thinking alternative solutions, I put up two references here that give you some idea of where this type of training could be going, and I invite you to read it if you have a time. Now, once you've installed it and use it, you have to ask yourself, is it worth the money? And one indicator is it being reimbursed by the national healthcare systems? This is a very old slide. It's about 10 years ago or 15 years old. I took from a German private practice author, and it illustrates you the differences in reimbursement for a number of cancer indications to the left across some European countries on the x-axis, and to the right, Germany. And Germany hasn't much improved. We don't have full coverage of PET-CT studies. And as Helen, I think, indicated yesterday, the fact that you do a fusion exam or a combined exam is not equally acknowledged across reimbursement schemes. So we still have a long way to go if we want to employ both modalities as a synergistic diagnostic test. Perhaps equally important, is it available throughout the world? We all talk about it, but certainly, and I appreciate that presentation by the colleague of mine yesterday afternoon, indicating the heterogeneity of adoption in Africa, a continent we frequently dismiss, I have to say, because it seems so far away, and yes, yet it is so close. And there's a really interesting paper supported by the IAA, written by Hedy Risak, that came out in Lancet a year or two ago, that shows you the distribution of medical imaging services across the world. And you can tell just by looking at the color, it's very heterogeneous just for a very simple technology like SPECT, let alone SPECT-CT. And then you compare that to the number of nuclear medicine physicians that are available. So there is a lot of things that need to be done to actually make it a more equal and inclusive scale up across the world, so that not only high-income countries can benefit from this technology. And this really mandates a joint effort, and it needs our engagement as a society and as scientists. Now, going forward, and I did a disclaimer in the beginning, I believe that one big jump will be using total body PET-CT. Now, people argue that it has a huge price tag, but with that price tag acknowledged, we can actually think of different use case scenarios, and perhaps total body PET-CT might become a machine that becomes more centralized with a 24/7 service, rather than what we, for example, experience in Austria, a 6-hour, 5-day-a-week type of approach. So we have to perhaps think differently if we make this type of investment to provide these services, similar to radiology services for a larger community. From a physics perspective, what I find most striking, that you cover multiple organs at the same time. So you can actually look, if you're doing research, you can look at inter-organ interactions, and first studies based on whole body systems already indicate a value in looking at metabolic uptake in a systematic manner across multiple organs as an adjunct to finding lesions and making oncology staging. We have to find out if it's really worth going for a total body system, or whether you can explore this with a whole body system. What we've heard in the previous talk, what is important is improve image quality. With the total body PET system, we can actually do 100 millisecond reconstructions and thus explore the dynamics of this machine even further, and we generate many more data of high statistical quality that now opens the floor to go beyond SUV max assessment, but really go for advanced data analytics. With PET MRI, and I shall add this, even though it's described as PET-CT, the power there is in the PET part. I haven't talked about the capacities of the CT, which now come with dual energy, so we can think of better lesion demarcation and tissue characterization, let alone dose saving. With PET MRI, I think we have to recognize the fact that while it is implemented and immersed in clinical routine, it's used merely as a fusion technique, not more. We've resolved some basic quantitative challenges, but we have failed to look at this from a perspective that we have multiparametric MRI even quantitative to some extent, and we have multi-tracer dynamic quantitative PET information. So if you think of this joint term like metabolic target volume, a descriptor of the volume of the lesion as well as the metabolic activity, we could think of similar synergistic parameters in PET MRI, but for some reason we have not done this, perhaps software being one limiting factor, but also perhaps an approach that fusion is good enough. But my thinking is if we want to advance PET-MR, we really have to explore that multiparametric area of this technique. I admit this, I'm not a SPECT-CT expert at all, but I believe the future in SPECT-CT, and again I point to the previous speaker on the dosimetry aspect, will be in quantification, and one of the key promoter of this technology, Dale Bailey, is in the room and has been, I'm citing one of these really interesting papers of his group here, has been working on this for a decade. And in addition, we might see advances in the detector technology that allow for multi-tracer imaging and certainly higher accurate or higher quality image data. So this is my take in addition to SPECT-CT moving into a whole body modality. So as a take-home, I really offer the significant potential of hybrid imaging is yet to be lifted, again, through a joint collaboration of physicists, radiopharmacists, and doctors. Now, the further outlook, I think, is threefold. I think we will see machines supporting machines. This is a graph I lifted from the internet, and it shows you in a patient diagnostic workflow where artificial intelligence, Irene Buvois will be speaking after me, has put an entrance, and I put up individual blocks where AI, at least as a research protocol, has been introduced that starts with denoising images, optimizing scan protocols, vendors accepting AI as an automatic scan preparation adjustment, and so there's a lot of time-saving potential and robustness or chances for increasing robustness of imaging. You see further, I will not go through into details, further ideas of where AI has been used and proposed, at least by means of papers and clinical research, in various aspects of this diagnostic workflow, from image acquisition to data interpretation to reporting and ultimately to prediction. So this is a really agile, dynamic field, and I think nuclear medicine is catching up, if not overtaking radiology on this arena, in aspiring to make use of AI in making exams more plausible and the reporting more robust, including therapy prediction. I believe ultimately we have to take a deep breath, and despite the fact being all nuclear medicine advocates and perhaps being imaging advocates, we have to understand that imaging, while it's being central to this, has to fulfill a role as a service provider to a larger patient management scheme. This is a paper that I definitely recommend you read from late Sam Gambier from Stanford, who talks about precision health and leans towards preventive care. In this cycle, imaging is central, nuclear medicine imaging for sure, if it's applicable, accurate, accessible, affordable, and automated. But perhaps more importantly, non-imaging biomarkers need to be put into relation to the imaging tests that we're performing, such as biosignals from wearables that could be indicative of stress levels or health status in general. And I believe that we should be accepting the fact that imaging alone might not explain or answer all the questions we have about patients and their health status. And I find this utterly important because we will see a global shift from reactive healthcare systems to preventive healthcare, which is less cost-intensive. And if we somehow find ways, and multiple groups are working on this, of merging imaging information with reference to healthy controls, with biodynamic information, epidemiology, et cetera, I believe we can actually turn the baton more to preventive care rather than reactive care only. So my final take-home message is hybrid imaging is to be understood as a stepping stone to going beyond imaging in a preventive healthcare setting. And if we want to enjoy this, we have to let go of professional vanities and make it a very personal affair. I want to leave you with a phrase, this is an old slide of mine, that came up by the inventor of PET MRI, or one of the inventors, who said that the future of combined imaging depends upon the ability to physically combine the necessary hardware. We can check that, but perhaps more importantly, to desire with such a coupling. And I cannot tell about your desire. My desire is very high, and I think the future, if we follow this, of hybrid imaging is bright. Thank you very much for your attention.
Thank you for that, Professor Beyer.